You have a patient number 1 with a potassium of 5.9, no ECG changes, and is asymptomatic. How do you deal with that? Patient number 2, you have a potassium of 7.1 and you're on your own. How will you manage such patient? And third clinical scenario, you're part of the cardiac arrest team. The blood gas returns after 2 minutes of CPR cycles. You have a potassium of 7.6 and a pH of 7.05. How will you manage this situation? All three hyperkalemia scenarios might have slightly different approaches. This is exactly what we are going to do in this module of systematic approach of how to deal with hyperkalemia in a very structured and cohesive manner. This particular video is about hyperkalemia and its investigation and management. So we will cover the initial assessment approach, really practical, the key investigation algorithm and how to look for the potential causes, management principles of immediate within 5 minutes, then within first half an hour, 1 hour, 4 to 6 hours, and how to monitor, and finally some special situations. Those of you who may not have watched the first part of this module, which is video 1, I have covered it separately. That is definitions, homeostasis, causes, and the clinical features, including my all favorite, the ECG changes of hyperkalemia with different stages. So the link will be provided in this video and it's on my channel. So please go back and watch it whenever you have the time, so that the both modules will link very nicely for your comprehensive learning. So initial assessment of patients with hyperkalemia, it's a time critical emergency. The doing of ECG and obtaining blood results has to be simultaneous, not successive, because time is essential. Step number 1, within the first minute, if there is high suspicion of hyperkalemia or the GP has sent in a patient with a high potassium reading, get the cardiac monitor attached, get a 12-lead ECG. If any suspicion of hyperkalemia changes, tall tentative waves, prolongation of the PR interval, QRS, etc., then you have to act on the ECG findings rather than reconfirmation. Step number 2, which is again simultaneous with step 1, get a venous access, which means a secure IV access, ideally a wide bore large cannula, and get all the bloods done, full blood count, renal function, metabolic chemistry, electrolytes, but most importantly an urgent VBG, a venous blood gas, which can give a wealth of information including acid, base, vellus, and lactate. Steps number 3 and 4. Step 3 I've already discussed, which is getting IV access at the same time as you would do the bloods. At the same time, the nursing staff or whoever is there with you should get the immediate cardiac membrane stabilization treatment and the potassium shifting treatment, calcium chloride, calcium gluconate, insulin, dextrose, salbutamol nebulizers. All of them should be pretty much ready, or at least they should be arranged as soon as possible when you are already in step 1. So that is really crucial. Step number 4, while you are doing all this, you need collateral history from patients, relative, family, ambulance crew who just dropped the patient off, a letter by the GP, the primary healthcare provider, all that information about quick renal history, any history of chronic kidney disease, any offending medications, any recent loss of volume, diarrhea, vomiting, gastroenteritis, any signs of infection, any other drugs like angiotensin receptor blockers, ACE inhibitors, metformin, any of these. This means you're getting simultaneous information. It's pretty much like when we used to work in stroke thrombolysis as registrar. So you're working for thrombolysis protocol plus getting history information as you are literally walking through towards the CT room. Finally, it's really crucial to also think about pseudohyperkalemia. If you're worried that the sample may be hemolyzed, a lot of times it happens when the GPs send the patient's blood test result through their health center to the hospital. There's a lag, there's a maybe 4 to 6 hours of delay, and that leads to subtle hemolysis, that leads to spurious reading. So if something doesn't add up and the patient looks fine, ECG, no ECG changes, then you do not have to rush towards treating the all the hyperkalemia or spurious hyperkalemia. In that case, you have time and you can urgently repeat the VBG and get the reconfirmation. So again, you have to act based on your local protocols, guidelines, but this is pseudohyperkalemia before treating an asymptomatic patient, especially in the absence of any ECG changes, is really important. Let's look at a very nice workflow of identifying the cause of hyperkalemia quickly. It's one of my most favorite flowcharts actually. Step number 1, once you have confirmed the hyperkalemia with the serum potassium above 5, in some labs it is above 5.5, the first step, as you said, is ECG. Is it normal or no? Plus the symptoms. So ECG is normal, but there are no symptoms. Then first of all, think about pseudohyperkalemia. Is it hemolyzed sample, or is it a prolonged tourniquet or ischemia? So that's number 1. Now we are talking about the causes. So then you need to confirm whether AKI or CKD, acute kidney injury or chronic kidney disease, is present. Yes, no. If it is present, then you think about all the causes: acute kidney injury, dehydration, nephrotoxic medications, and also dietary intake and the stage of CKD, whether the patient is a hemodialysis patient. Sometimes they have missed their dialysis session. So that's one part of the renal etiology. Step number 3, once you have addressed the kidney part, AKI or CKD, then you go on to the second commonest cause, which is the drugs, medications, which can lead to hyperkalemia. If the answer to that is yes, by looking at the patient's medication history, if the patient has just come into the hospital, or look at the drug chart in the hospital, the treatment chart, then stop any or all offending medications: ACE inhibitors, ARBs, metformin, potassium sparing diuretics, etc., and reassess the potassium reading in 24 to 48 hours and look at the other alternate agents if you have to consider antihypertensives and diabetic medications. After looking at the drug chart, then the next is you need to look at the evidence of transcellular shift of the potassium. So those of you who have not seen the first video of this series, please look at it. I've discussed in detail about the transcellular shift as one of the causes. So essentially we are talking about the shift of potassium from intracellular to extracellular compartment, usually in conditions like diabetic ketoacidosis. So if that is the case, then you just need to treat and look at the etiology from DKA perspective and other causes as well. Once you have looked at the potassium transcellular shift, if still the answer is no, then look at the sodium. If the sodium is low and potassium is high, plus there is evidence of hypotension, then please suspect or at least think about adrenal insufficiency. So you might need random morning cortisol level at the 9 a.m. cortisol. And if there is any suspicion or suggestion of adrenal suppression, then you can start hydrocortisone intravenously if a crisis is suspected. And then you can also check the renin and aldosterone levels before initiating any steroid replacement as soon as possible, endocrinology referral. And also if the cortisol is low, then you might have to do the short synectin test, which is the ACTH stimulation test to confirm the diagnosis. It may not be as simple as this flow chart, and a lot of times you will have multiple components of this flow chart running. You might have a patient with renal etiology and then combination of drugs. There might be some acidosis due to sepsis or diabetes. So it may be multifactorial, or if it's still the diagnosis is unclear despite all this, then you may have to address all these factors in more detail and look you can seek input from nephrology colleagues. Serum electrolytes, why are they important? Number 1, potassium, for confirmation and reconfirmation of your diagnosis, especially in asymptomatic patients and without any ECG changes. Sodium, it's important because hyponatremia can coexist, and also it can amplify the toxicity and metabolic encephalopathy, plus adrenal insufficiency we discussed in the last slide. Serum calcium, really important because it can have its effects on ECG, corrected QT interval, cardiotoxicity, because hyperkalemia can worsen the thresholds for arrhythmias. Same as phosphate. If phosphate is elevated, then it can be high in tumor lysis syndrome or acute kidney injury or even in CKD. So again, important. Magnesium, hypomagnesemia and magnesium disorders can go with potassium disorders. Again, worsening of the QTC, corrected QT interval and cardiotoxicity. Coming to the renal function, number 2, urea, which would indicate possibility of dehydration, volume depletion. Serum creatinine, also acute in AKI and CKD, especially if you compare with the previous baseline, and if it's worse, it indicates in renal etiology or at least renal contribution from renal side of the hyperkalemia etiology. It may be primary renal or secondary renal due to some other reasons. EGFR will tell you about the long-term status of the kidney function in terms of CKD. Urine output will tell us whether it's oliguria, oliguric AKI, non-oliguric AKI, etc., or even obstructive nephropathy. The other 2 investigations are pretty sophisticated actually. Urine potassium creatinine ratio, that is to differentiate between renal and extrarenal. If the ratio is high, that indicates kidneys are appropriately excreting potassium. So that would indicate extra renal causes. However, if the ratio is low, that indicates it could be intrinsic renal etiology for hyperkalemia. Same as spot urinary sodium. If the urine sodium is low, that means the body is to retain sodium in response to hypovolemia. So that would indicate the volume status. Glucose and acid-base balance we have discussed. Glucose, VBG, blood gas, whether it's arterial or venous, acidosis, high anion gap, low anion gap, metabolic acidosis, and also the bicarbonate status in DKA, acidosis with pH. All of them are really crucial. We have discussed in our previous slides. So all these investigations are really essential in hyperkalemia. CK myoglobin, you can think of the rhabdomyolysis as etiology. If you are suspecting heat exhaustion, heat stroke, or rhabdomyolysis due to drug-induced etiologies. LDH and heptoglobin, direct Coombs test, retic count, peripheral smear, all of them for hemolytic anemias. Also, uric acid and phosphate if you're suspecting tumor lysis syndrome. Same as full blood count, because erythrocytosis, massive leukocytosis, they can also lead to hemolysis and blood cell destruction leading to hyperkalemia. And especially if you're suspecting pseudohyperkalemia, all these investigations are crucial. Coming to endocrine and targeted panel, random cortisol if you're suspecting adrenal insufficiency, renin aldosterone confirmation of the levels if you're suspecting type 4 renal tubular acidosis plus Addison's, thyroid function if you're suspecting hypothyroidism, although that rarely causes hyperkalemia on its own. Medication levels, some patients may be on immunosuppressants like tacrolimus and also digoxin. Digoxin and renal failure can be a very deadly combination, especially with ECG changes. So you must do digoxin levels in anyone that you're suspecting digoxin toxicity. And also urinary potassium ultimately to look at whether it's adrenal versus renal etiology. So that's really crucial. In terms of monitoring the baseline, the regular 12-lead ECG monitoring, continuous cardiac monitoring if there's hyperkalemia. You want to lower the potassium to a safe range of below 5.5. And monitoring continuous glucose regularly if you're suspecting DKA or if you're treating hyperkalemia with insulin and dextrose, and periodic monitoring of potassium with VBGs. And lastly, do not forget about urine output monitoring, and the minimum target should be 0.5 to 1 ml per kilogram per hour of a patient's body weight. Management of hyperkalemia, it's a three-step approach. Stabilize, shift, remove. Stabilize the cardiac membrane, shift the potassium intracellularly, and remove the potassium out from the body. Now, please remember the first two steps, step 1 and 2, are only temporizing measures, which means they are there to buy you time. They're not definitive treatments. The definitive treatment of removal from the body is step number 3. So, calcium first, stabilize, shift second, remove third in this particular order. Now remember, calcium without shifting is incomplete, and shifting without removing is only temporary, as we said earlier. Step 1 of management, cardiac membrane stabilization. Intravenous calcium gluconate or calcium chloride, we will come to that. The most urgent investigation to protect the cardiac membrane and the patient's life. So calcium gluconate or chloride, remember both of them, they do not lower the serum potassium or plasma potassium. They just stabilize the cardiac membrane while you're trying to shift the potassium intracellularly, and then eventually you're trying to clear it from the body. So it's only a temporary measure to stabilize, and it just lasts for an hour or so. The dose, remember the formula of 10. So 10% of calcium gluconate given in a volume of 10 ml IV or over a slow push of around 5 to 10 minutes if time permits. You can dilute it in 100 ml if there is more time, but and you have to monitor the ECG changes every 5 minutes to make sure it's working. It's only IV. You cannot give it intramuscularly or subcutaneously. Works within a very short amount of time, within 1 to 3 minutes, but it doesn't last more than 60 minutes, and the effect usually wanes after that. So you have to remove the potassium from the body, plus shifting of intracellular potassium is a key priority here. In case you have a central line or a bigger access, a big line, then calcium chloride can be considered. What are the indications for giving calcium gluconate intravenously? Any ECG changes irrespective of the absolute potassium level. Number two, if the potassium is above 6.5, regardless of the ECG changes, because it's a very high risk for arrhythmia and cardiac arrest. If the potassium is 6 to 6.4 and is associated with symptoms, fatigability, palpitations, weakness, etc., or if there is a cardiac arrest situation with hyperkalemia as one of the causes, electrolyte abnormalities, the 4 H's and 4 T's, then yes, you have to give it irrespective. And generally speaking, you do not wait for labs if ECG is confirmatory of the findings. Mechanism, it stabilizes cardiac membrane by increasing the threshold for the cardiac action potential, which means the membrane remains resistant or immune to the effect of depolarization and hence arrhythmias, and it restores the gap between the resting membrane potential and the threshold. It does not alter any potassium levels intracellularly or extracellularly, and it has no role on the circulating potassium level. You have to be cautious if you're suspecting digoxin toxicity, then calcium can worsen it, so you might have to give it slowly in that case. Similarly, in hyperkalemia, you have to monitor for bradycardia, bradyarrhythmias. And as I said before, check ECG after successive doses to assess the response. And calcium chloride is ideal because it's 3 times more potent, but for that you need a bigger IV access, either a large bore cannula with good flush, or PICC line, which is peripherally inserted central catheter, or central line in ICU settings. However, follow your local protocols and guidelines. Extravasation of calcium chloride or calcium gluconate can lead to a lot of tissue necrosis and complications, so that should be avoided. Second step is shifting potassium into cells, which should happen simultaneously. The mainstay is insulin and dextrose, 10 units of intravenous act rapid and 50 ml of 50% dextrose IV, given over 15 to 30 minutes, and the effect lasts for 4 to 6 hours. It lowers potassium by a good amount of 0.5 to 1.5 millimoles per liter, which is potentially extremely crucial. Imagine somebody with a potassium of 6.5. If you use it, and if it comes down to below 6, around 5.5 or 5 to 5.5, that's like a gold. Most reliable shifting agent. Hypoglycemia is one complication because you're giving insulin, so you have to monitor blood glucose every 30 minutes for the next 2 hours or so. And if glucose is low, then you can give additional dextrose, 5%, depending upon the glucose readings. The other mechanism is salbutamol nebulizer, given in a big dose, 10 to 20 milligrams, either back-to-back, 10 to 10 milligrams, or you can just give 20 milligrams depending upon the situation. In fact, this is the first line and one of the easiest to administer. As soon as we have the ECG, the first thing I would ask the nurse is to please bring the nebulizer straight away, while the second nurse is preparing the IV dextrose and glucose grade plus, getting calcium chloride, etc. So logistically, it's the easiest to administer and give you crucial amount of time, buy your time while you're administering the other definitive treatments. Works within half an hour and the effect lasts up to 2 hours. And it can lower serum potassium or plasma potassium by around 0.5 to 1 millimole. Again, really, really important. How does it work? The beta-2 stimulation shifts the potassiums intracellularly, and it's additive to the insulin and dextrose effect. Avoid if you're suspecting tachycardia, cardiac arrhythmia, or anyone with cardiovascular risk factors. In that situation, you have to be careful. It may not be effective in dialysis patients. And as I said, it's a synergistic effect of insulin and dextrose, and it's really, really crucial to administer it early. Sodium bicarbonate, not one of the first or second lines. I'll explain why. You can give a small volume of physiological sodium bicarb, which is 1.26% or 1.4%. Not the higher concentration ones, but definitely not the 8.4%, because that's usually used by the ICU in ICU settings and cardiac arrest situations. Works within half an hour to 1 hour, and the effect can last slightly longer than the others, which is 2 to 6 hours. But it's only indicated if pH is less than 7.1 or if it's a cardiac arrest situation. It does little, to sort of stabilize potassium at a normal pH level. So again, it's in severe acidosis, and again, it's usually useful in DKA and lactic acidosis, but the hypertonic concentration of sodium bicarb should be definitely avoided in normal ward situations. Step number 3, which is the definitive treatment, is removal of potassium from the body. In module 1, we discussed about the physiology. 90% of the potassium is handled by the kidneys if they're working efficiently and effectively. Around 10%, 7 to 10% is handled by the gut through stools. So here the importance lies. So first line is Furosemide. You can try as a loop diuretic, relatively moderately good doses, 40 to 120 milligrams intravenously in acute situation. Works within half an hour, can last up to 4 to 6 hours. The effect is chelidurasis, so potassium is lost. But it only works if the kidneys are responsive. In advanced CKD 5 end-stage renal failure patients for anuric, it may not work. Again, it's selectively used. Sodium zirconium cyclosilicate, potassium binder. It's a non-organic binder. 10 grams oral 3 times a day can be given in the first 48 hours, and maintenance dose is around 5 to 10 grams once a day, depending upon the potassium. One of the beauties with this new agent is that it's much GI friendly, unlike the old binders like a calcium resonium, for which you need a lot of lactulose and fluid to work, and in patients who are already renal failure patients and heart failure patients, that would be quite difficult to achieve. It can be really cumbersome for the patients, and it can also be used hence in renal failure because it has minimum effect. So that's an advantage. One of the drugs most liked by the nephrologists currently is Petiramur, because it does not lead to sodium retention, because potassium and sodium can be bound, can be linked. If you're exchanging potassium for sodium, then the body will retain the sodium. But in Petiramur, it's actually potassium is exchanged for calcium, which makes it far more physiological and ideal in renal failure patients. So again, dose 8.4 grams oral once a day, and it works slower than the sodium zirconium cyclosilicate, but the effect can last longer. Calcium resonium, it used to be given up until 4 or 5 years ago, but because of the novel new drugs, it has been superseded. So it's only considered if you do not have any other options. Relatively bigger doses are needed, 15 to 30 grams orally, and it's unpalatable as an agent, and requires pretty good doses of lactulose and oral fluids, as I said before. So limited evidence, doesn't work. A lot of GI intolerance, and patients do not like it. Hemodialysis, the definitive treatment of potassium removal from the body, especially in patients with acute kidney injury, anuria, who do not have any other options, and the potassium is not properly managed medically. Hence, when to escalate to dialysis, one of the very important MRCP, USMLE, OSCE exams for students. Indications will be resistant hyperkalemia despite maximal medical therapy. If the potassium remains static or continues to bounce back, that means the dialysis needs to be started. If it's refractory, especially within a couple of hours of treatment, or if the patient is anuric with the potassium above 6. ECG changes despite giving the calcium chloride and calcium gluconate, that means cardiac membrane stabilization is not working properly. And in advanced CKD patients who have acute decompensation, they may need urgent initiation of hemodialysis as a modality to correct electrolytes. How many times we see patients admitted because of end-stage renal failure who have now progressed to the need for renal replacement therapy. And again, if we have cardiac arrest situation and suspected hyperkalemia, again, after stabilization, if the return of spontaneous circulation is achieved, then dialysis would be indicated for clearance of potassium from the body as per ICU protocol. I think this slide is probably the most important from exam point of view. Any MRCP candidates, USMLE step 1, 2, OSCE exams for medical schools plus Arab board, FCPS in Pakistan, this is the slide. Diabetic ketoacidosis, the key pearls. There is hyperkalemia, but the total body potassium may be low. So it's a shifting problem, not the content problem. So again, once you start replacing with insulin, there is a risk of rebound hypokalemia because the potassium is going to be shifted intracellularly. That's why the frequent monitoring and replacement as per DKA protocol is extremely crucial. You already know if the potassium is above 5, you don't replace. If it's between 3.5 to 5.5, you replace according to the protocol, which is usually like 20 millimoles. If it's below 3.5, you replace 40 millimoles, etc., etc. And you have to stop insulin if the potassium goes below 3.5, because you don't want further shifting. So depending upon your protocol, local policy and guideline, use it. And you have to frequently monitor and adjust the potassium and insulin and glucose replacement accordingly. Do not give calcium unless you have ECG changes in patients with diabetic ketoacidosis, and refer to your local protocols. Number 2, CKD dialysis patients. Again, there is no renal excretion, hence you have very limited options of clearing potassium. The shifting drugs, salbutamol, insulin, dex will still work. Furosemide doesn't work very well in advanced renal failure patients. However, you need to go to immediate dialysis if indicated, especially if the potassium is not improving. So there is no other way out. You need to inform nephrologists as soon as possible. In post-arrest situation, we touched in the last slide. Post-cardiac arrest, hyperkalemia may be the cause of cardiac arrest. You remember 4 H's, 4 T's. So again, when we are talking about the 4 H's, it's one of them is hypokalemia, electrolyte abnormalities, etc., etc. So you need calcium gluconate during CPR, IV bicarbonate to correct acidosis, dialysis immediate post-ROSC achievement, and avoid succinylcholine if intubation is attempted, because it can lead to potassium surge. Remember the causes in our module 1. One of them was anesthetic agents like succinylcholine because of the release from the tissues and muscles. Addison's disease we discussed, low sodium, high potassium, and hypotension, or evidence of previous adrenal suppression. Think Addison's. Intravenous hydrocortisone can be literally life-saving, and then a random cortisol, short synectin test, etc. Endocrine review if needed. Now you have achieved the potassium stabilization, shifting, and removal from the body. So how will you monitor the treatment endpoints, and what the time is of real essence and crucial in this situation? First 15 minutes, we have discussed about the first 5 minutes of IV access, doing ECG, doing bloods at the same time, especially VBG, and then once you have confirmed, you need to give the insulin, dextrose, the shifting treatment. That is the immediate one. Step number 2 involves 30 to 60 minutes. So within the next hour, what are you going to do? Monitor glucose, because there is a risk of hypoglycemia, clinical reassessment of the patient with symptoms, look at the ECG for the trends, and finally salbutamol labs if not given earlier on, and also think about the removal plan. After the first hour, between the first and second hour, the key priority, this is the crucial time because the potassium which you have shifted might bounce back. So early monitoring, repeat VBG, look at the potassium, monitor blood sugar, ECG reassessment to make sure that the changes have improved and stabilized. If the potassium is less than 5.5 and ECG is normal, then you can step down. However, if the potassium is still above 6, either you need to reinitiate the process or you have to escalate, whichever the case may be. Between 4th and 6th hour, this is a crucial window when the potassium that has been shifted might bounce back. So constant or regular monitoring of potassium, review all the drug treatment given and medication chart, assess for any potential nephrotoxic or drugs which can raise potassium, those should be held or cancelled, whichever the case may be. Now look at the causes. Remember the algorithm, re-establish what exactly are the causes, and nephrology consultation early if needed. When would you escalate along all this spectrum? Number 1, if the potassium is above 6.5 after 1 hour of this aggressive medical management, or at the start if you're really worried and it's a sign pattern rhythm or extremely complex ECG changes, then you have to escalate to ICU straight away. If you have persistent QRS finding despite treatment, and if there is potential of cardiac arrhythmia despite cardiac membrane stabilization, any patient who is anuric and is not passing urine and has got acute kidney injury, that's a potential red flag, because no matter what you do, potassium will not improve. So dialysis may be initiated as soon as possible. So ICU and or nephrology input as soon as possible. Hemodynamic instability of any reason should prompt you to escalate to ICU, and also follow your local protocols and policies and guidelines for potassium management in your institutions. Key takeaway messages. So the following 6 clinical pearls are really important for every practitioner to know. First of all, recognize early any high risk factor for potassium, hyperkalemia, you need to have a high clinical index of suspicion, and that's why you need to get ECG as soon as possible, because peak T waves assume it's hyperkalemia until proven otherwise, and you don't have to wait for confirmation if you have a high degree of suspicion. You need to think of stabilizing the patient in the cardiac membrane and shifting treatments, plus while you're awaiting confirmation of other investigations. In terms of ECG, as I said, ECG is the first priority before you even consider anything else. You need to get it as soon as possible on admission or on the first encounter with the patient. Any QRS prolongation with a high potassium hyperkalemia of 6.5 and above, it's extremely urgent as a priority to stabilize the cardiac membrane. And ECG and blood taking should be simultaneous, as we discussed earlier. Serial ECGs to monitor the effect of the treatment should also be high priority. Cardiac membrane stabilization is one of the first priorities. Calcium chloride or gluconate. Do not wait for the final confirmation. VBG is your gold standard, and repeat ECG after 5 minutes of giving calcium chloride or gluconate to make sure that the ECG changes have subsided. And digoxin, you need to be very careful if you have to give calcium chloride or gluconate, because digoxin, associated digoxin can lead to toxicity. So give it slowly if you have to give calcium chloride or gluconate. After stabilization, the next key steps are shift and then remove. So both should work simultaneously while you're stabilizing. Insulin dextrose is the gold standard. Salbutamol nebs can buy you a crucial amount of time. Once you've done this, shifting is only temporary. It will bounce back. The potassium will bounce back. So you need to have a definitive plan of removal of potassium from the body, plus looking at the causes. So that's really crucial. Early monitoring of glucose with ECG changes will be very crucial because of the risk of hypoglycemia. Also, if the patient is asymptomatic, the ECG changes are not there, and the potassium reading is high, and you have time, then you need to confirm pseudohyperkalemia, as we discussed before. So urgent VBG will be crucial in this situation, especially if there is erythrocytosis or high or the risk of hemolytic anemia or delay in transferring the sample to the lab. And eventually, once you've done all the three main steps of stabilization, shifting, and removal, you need to look at the cause and try and remove the cause, whether it's drugs, renal failure, sepsis, dehydration, etc. The definitive treatment will follow the cause, and the cause has to be picked up as soon as possible during all this treatment continuum.